Good morning. Happy Sunday. We are going to do the week 5 walkthrough. Hopefully, you're finding these videos at least somewhat helpful to guide you through each week. So, you click on, actually, it will be your home page. After I get the video posted, then I will make it the home. This will be your home page, your landing page. And this link will take you back to the module. And then these are the course objectives from the syllabus for the week. And this week, we're going to be talking about birth, the postpartum period, as well as infancy. So let's actually go back to the module, which has been open for a week. So hopefully people have been able to see what is there. Let me go to your view as a student. And then you don't have to see all my extra things there. So week 4, we're coming to a close there. So week 5. So we start with the overview, which again is also your home page. These tabs will take you to a summary of each of the topics for the week. So for example, the birth experience. Here are your objectives. We're just going to go over a basic understanding, not deep into the understanding of the birth process. That's for another time and place. But this is just basic and how the emotions and physical changes might affect growth and development of the mother, the father, any of the family. And then also looking at the postpartum period. Again, not in terrible detail, but postpartum depression, caring for the baby, excuse me, and then moving into infancy. So we will, then you have your reading. So you just click on the link and that should take you to another window. And there you can start to do your reading. And you should be able to just go right back to that. And then there is a link to the lesson and to the activity, and then to your journal questions for your journal. And the same applies for the postpartum period. So there are the objectives, and then your reading and lesson are actually combined for this particular topic because it was really difficult for me to separate out the lesson from the reading, because what I have done is a big shout out to my colleague, Ms. Angela Clark, who I work with. We're both OB content experts. And so she gave me permission to use her postpartum slides and her birth slides as well. And she also has given me permission to use her Zoom recording. So she'll do something similar to what I do for these walkthroughs. And then, and so she said that was fine. And so I think combining that as your reading and your lesson was the best way to go about this. And then you also have an activity to do, and then your one question for your journal regarding the postpartum period. And then if you go to the infancy tab, again, there are your objectives. There is your reading. There's a little note there that says the chapters are very similar, which they are. So choose the one that works best for your learning. So if you would like to read all 3 of them, that's perfectly up to you. If you like the way one is formatted better, then choose that one. That's fine as well. And then there is your lesson, and then the activity for you, and then your 2 journal entries. So then if we go back to the course objectives, we can go back to the module. And then you'll see each lesson, right? And they are numbered, the 5.1. If we go to the birth experience, for example, there we go. It will take you back to the module. And it's set up the same way as it was previously with your objectives, your reading, and then it will go, oops, I should have warned you. There are what might be considered graphic pictures to some people regarding the birth experience. So I should tell you that. And so there is the PowerPoint. There are some pictures, and then we go through cultural influences. There's your activity, and again the journal. So it's all set up that way. You can always, on the left menu here, go back to modules, and it should take you to the one that's open, which it does. So let's go through, let's go back to the overview. Let's start with the birth experience, and then we'll go through each, the lesson and the activity so that you have an idea of the expectations. So there is the reading. This is the birth experience. Let's go to the lesson where we just were. So be able to explain the 4 stages of labor and delivery, describe physiological changes that occur, excuse me, with each stage of labor, discuss psychological and emotional responses that mothers and families may experience during the labor and delivery, analyze the role of the support systems during the birth process, and examine how culture, beliefs, and practices influence the birth experience. And that's kind of where your activity for this will come into play. So there is your reading again. There is the PowerPoint, which I will come back to in a moment. I wanted to show you the pictures. So this is actually a water birth. They have big tubs, and so the mother gives birth in the tub with the water, and you can see the midwife or doula there helping. The one in the middle is actually a C-section birth, and the baby's actually coming out breech, so butt first, behind buttocks first. And then the one on the right-hand side is a vaginal delivery. It looks like those might be midwives or doulas. And there's the mother right there. So I thought pictures, for those of you that haven't experienced that, might find that somewhat interesting. So let's move into the PowerPoint and kind of talk you through what you need to know. And for those of you that have not had a birth experience, then hopefully this will shed some light on that for you. Hopefully this will load a little bit quicker. I might change it so that it opens right in the page. Sometimes that's faster. What you barking at? It's okay. Or we can download it, which might work faster. There we go. So I'll just open it this way. I'll go back and change that access. So let's do the slideshow from the beginning. So labor and delivery. This is, again, thank you to my colleague, Ms. Angela Clark, with whom I work. And so we're going to talk about the 4 stages of labor, describe physiological changes that occur, and emotional and psychological responses. So the labor and delivery process, remember that we have gone through the prenatal development, right? We talked about genetics and prenatal last week. And so the woman's gotten the prenatal care, hopefully. We talked about ways to make sure that they're coming to their prenatal appointments and the importance of those. And so now the woman thinks or is in labor. And so there are different places where you can give birth. We're going to consider this in the hospital because that's where the healthcare providers generally are. But you can do home birth, oftentimes with a midwife or a doula. You can do water births. I have one of my friends from nursing school actually is a nurse practitioner and women's health nurse practitioner and performs water home births. And so there are different places, different ways to do that. We want to make sure that the mom is safe and cared for, that the baby is safe and cared for appropriately. So intrapartum is when you're in labor. So partum would be being pregnant. Intrapartum right? So there's like postpartum, prenatal, interpartum, right? Okay, so there's the different stages. And so interpartum is the birth process. And so there's a lot of things that come into play when we're caring for this particular person. And so changes that precede labor, things that the woman might experience, keep in mind that every person, every woman's birth experience is a little bit different. So it's one of those things that when you come to the therapeutic communication to really figure out what should I share that's going to help them? Are they asking for me to share something or not? So kind of keep that in mind. But backache, maybe some weight loss, lightening, when the baby kind of drops down into the pelvis, contractions. There might be some vaginal discharge, actually with some blood in it. There is a mucus plug that covers the opening of the cervix. And so when that gets pushed out, there can be blood, maybe some GI changes, diarrhea, constipation. Oftentimes it's called nesting behavior. There is a burst of energy, like the woman's like, yeah, we need to do this, and all that. Cervical ripening means that the cervix is thinning and effacing. So it's thinning and so if you think about the cervix, it would be, whoops, there we go, camera closed. And so what it has to do is it has to open up and kind of thin out. So, oops, there we go. So that the baby can actually pass through the opening. So that's cervical ripening. And then rupture of membranes. So the baby has been in the amniotic sac. And so that can rupture spontaneously, which it often does as the baby goes into the pelvis and the membranes rupture. All right. But again, not every woman experiences this. And in fact, some women don't even go through labor because they get, if gestation is 40 weeks and they're 41 weeks, then they may end up having a C-section because it's healthier for the mom and the baby. We'll talk about that a little bit later. And so when you talk about having the baby, factors that have to do with the birth process. So the passenger, they call them the 5 Ps. And so the passenger is what's inside and then has to be delivered out. And so that is the fetus or the baby, but also the placenta, because the placenta is attached on the inside of to the inside of the uterus. And so those are the things that have to come out. And they come out through the passageway, which is the pelvis. And so these are pictures of a pelvis. Let me try over here. There we go. So pictures of the pelvis. You don't have to know the terms at all, but these are just different shapes. And so you could see perhaps why, especially if it's a larger baby, why there might be problems with the baby being delivered, as well as the position of the baby, because we'll talk about that as well. So you've got the baby and the placenta. They're going to come through the pelvis. What helps them to get through the pelvis and to continue moving down are the uterine contractions. So the uterus is actually a muscle. And so it contracts. There's a signal in the brain and oxytocin gets sent and it starts to contract. And every time it contracts, then it's pushing, right, the fundus, the top part, and it's pushing, I mean, the whole uterus contracts, but it's pushing the baby out. And once the baby comes out, then the placenta will also be delivered. And so then we're also looking at the position, maternal position, as well as the fetal position. And so if you look at the way the baby can, so this is a pelvis, and this shows you the position that the baby is in. These positions are okay. It shows you where the skull is here, so you can see how the baby would be coming out. And then you've got here where the face is actually we call it the presenting part, the parts that's presenting first. So the face might be coming out instead of the head. And then this is actually a breech. So this is similar to that C-section picture that we looked at, and where the behind, the buttocks are what's coming out first. Sometimes it can be a little confusing to know which way is up per se. And so we'll do an ultrasound to see the position of the baby. Generally speaking, if the baby is in a breech position, they will perform a cesarean section because it's not safe to deliver vaginally. Having said that, that doesn't mean that there haven't been babies born breech or what we would call the like feet, if the feet are the presenting part. I have actually seen what's called a double footling breech, where the 1 foot kind of came out first, and then the other feet, and then the baby just kind of not fell, but moved its way down. The concern with that is that the head might get stuck in the pelvis. And so that's kind of dangerous, and they will want to do a C-section, but there just wasn't time in this particular instance for that. The other thing that plays into the birth process is the psychosocial response. So the maternal stress, tension, anxiety, I would say also support, the culture. In some cultures, it's not looked well upon the woman showing emotion or pain. And there's a lot of pain. I've had 3 babies. It's painful. But it kind of, the endorphins come into play and you say, oh, that wasn't that bad. And then you have another one and you're like, oh yeah, I remember. But anyway, but depending on how anxious, how tense, if it's premature, if the baby's late, many different factors can play into that. And so you can do what's called natural childbirth, where there are no medications given. Medications often, if they are relaxing the mother, tend to relax the baby, so much so that sometimes their respiratory effort can be decreased, and we don't want that. We want our baby to be breathing. That's a good thing. And so they can also give what's called an epidural, which goes into the epidural space in the back and the spinal cord, which relaxes the lower half, which really takes a lot of the pain away. You still feel pressure, but not pain. Also, the baby's position can affect the pain. And so generally speaking, you want it to be kind of like, let's see, which one's a good example? Like one of the ones up top here, this left vertex, where the head will be coming, actually, I guess I like that one best here, where the head will be the presenting part, and it will often be this part of the head that's coming out first. And then the baby goes under the pelvic bone and kind of dips up like that. Now imagine that the baby's flipped the other way. And so their face is going to be coming out first instead of the top of the head. This part is coming out first. Well, this part can tend to get stuck on the pelvic bone, so it's a little more difficult to push the baby out, but also the baby's back and behind are pushing against the spine, and that can be a lot more painful during labor. Okay, let's go on to the stages, which is really what we would like to know about. And so there are 4 stages, if you will, in the labor process. And so stages of childbirth, excuse me. So this would be the inside. This is hopefully what is a good position. The head is down. We're down in the pelvis. And so this is the fetus, the baby. You've got the uterus, which is the muscle. Right, that's the uterus holding the baby there, the vagina and the cervix. So the cervix is the bottom of the uterus, and then the vagina is more of the passageway where the baby will come out. The placenta is back here hidden by the baby right now, but it is embedded into the uterus, and that is where the baby gets their nutrition. So stage 1 is the first stage, and that is where the uterus is contracting, and we are trying to get the cervix to open up to 10 centimeters. And again, that 10 centimeters, I don't know who measures it, but that's what we're hoping for. Many women will feel this intense urge to push once the body gets to 10 centimeters. Some women don't. And so the healthcare team will say, okay, you can push now. And so the first stage is getting to the 10 centimeters. And then the second stage is what's called full dilation to birth. So the cervix is dilated, it's effaced, it's gotten thinner. And so the contractions and the pushing, the contractions are really what are part of the second stage, pushing, helping to push the baby out. And so then, so stage 2, there we go. And so now the third stage is from the delivery of the neonate to the placenta. So stage 2, it says birth. That's kind of a misnomer. It's actually the third stage where the baby is born, but the second stage is up until the birth, right? Till the baby's coming out. The baby's not quite out yet. And so then the third stage, the baby has come out, and then you have the delivery of the placenta. So here's the placenta. And so it will detach. There's a hormonal cue that happens in the brain once the cord is cut, because the umbilical cord is the bond between the baby and the nutrition, the placenta. And so once the cord is cut, there is a chemical process that happens, and the uterus starts to pull away from, I'm sorry, the placenta starts to pull away from the uterus, and then, excuse me, it comes out. It is delivered, if you will. And so the fourth stage is delivery of the placenta to the mother being stabilized, because there's a lot of things that happen. There's some blood loss, that the mom can get some chills, like they're just really shaky, and the whole body, the body just went through this enormous change, and so has to sort of recover from that. And so these are some pictures of different positions. This is again a picture of a water birth, and so it looks, can't tell if that's partner or the midwife. But anyway, and there's the sterile table back there, because those look like sterile gloves to me. So my guess is they're waiting. Now she's sitting on a cushion. There's some back pressure here, which is helpful. This woman's leaning over a ball. These balls are great. They're great. They also have ones that are kind of shaped like a peanut. And so the woman can sit on that to kind of help spread the pelvis. So there's some hip pressure there. There's some back pressure there. And so those are non-medicated ways to help with pain during labor. Breathing, music, different scents in the room. Lavender's really good, aromatherapy, all those kind of things are good, whatever works for that particular person. And then, excuse me. And so then different pharmacological, so that means medication to help with pain. And so this woman's actually receiving nitrous oxide, which is what you get at the dentist, right? And it just kind of takes the edge off and doesn't affect the baby too badly. And then you can do an epidural. This would be a block. This looks like a pudendal block. So they're actually doing it around the opening, and it goes into the muscle and kind of numbs up exactly the place right around the opening. And then this is an epidural in the spinal cord. There's the epidural space. And the thing is, you have to assume this particular position, which is really difficult to do when you're having contractions. And they have to find the exact right space in which to place the medication and hope that it is affecting both legs and not just one leg. And then when it wears off, hopefully everything goes back to normal, the way it was prior. So different things there. It's always good as the healthcare provider to explain all the options that are available, to verify, ask if there's any questions, and to let them know what all the options are. The other thing that's really important, I think, is to advocate for what the mother wants. So oftentimes you'll be in the room and the mother will kind of be looking at you, but the partner or family member who's ever in there is saying, "Oh no, they don't want to do that. No, no, no. They told me they don't want to do that." But the poor woman in labor is just kind of looking at you like, "Help me, help me. I changed my mind. Give me something for pain." Um, so sometimes you may, again, here comes that therapeutic communication, where you may actually have to ask the family member to leave, or wait till they leave, and then talk with the mother and see what she actually would like to have happen, what her goal is. And so just a little more in explaining the different stages again. So stage 1, again, averages 12 hours in duration. It depends on whether it's the first baby, or third or fourth baby. Sometimes that can affect labor as well. In the first stage, you can give opioids. Fentanyl is one, sedatives, the nitrous oxide that we talked about. And stage 1 traditionally has been broken into excuse me, I'm sorry, I don't know what's happening to me today. Stage 1 has traditionally been divided into latent, active, and transition. However, ACOG, American College of Gynecologists, has now said that they're not considering the transition phase, which I think anybody that's had a baby would tend to disagree with. However, they now say that it's latent and active. You don't need to know that for this class, but I'm just clarifying. And so the latent phase is the longest. We're hoping to get to 3 cent. We just want to keep progressing. So 3 centimeters, and we want some contractions. They're probably irregular. You can go 5 minutes between, and then 20 minutes between. They're not very regular. And then when you move more into active labor, the contractions should start to get more regular, and then they will start to get stronger. And so we can do positioning, we can do pain meds, we can play music, we massage, all those kind of things. And if you are the nurse, then you're probably in the room a lot of the time. You're doing your documentation in the room. There may be respiratory therapy coming in. The provider will come in and check. Every so often, lab might come to draw labs. So there are people in and out of the room. So stage 2, again, here is some nitrous. Here is the picture of the epidural. This particular thing is like a birthing bar, they call it. So it kind of helps the woman to spread the pelvis out, but they can also lean, like that kind of, which is nice. And so stage 2 is where we said we got to the full dilation. We got to the 10 centimeters, and then and the contractions are coming every 1 to 2 minutes. So we're pushing and pushing and pushing and pushing. And so we want to try and position, and the breathing is really important, because if the mother hyperventilates, that's not a good thing. So a lot of times we have to say, okay, breathe with me. Or when they're pushing, it's take a breath, and then you hold your breath, and then you push, 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 usually to the count of 10. That's usually the goal. So they'll say push 1, 2, 3, 4. And that's something that the partner, the family member, whoever the support, call them the support person, that they can help with. And they can be helping through this by cooling washcloths, holding hands, doing massages, not sitting on the couch on their telephone, or in a chair on their telephone. But those kind of things are very helpful, as well as listening to the mother, because at some point she will probably say, "Don't touch me," which is perfectly acceptable, because it's just, there's so much sensory overload going on at this point that that's totally understandable. Now, at this point, we usually give epidurals. Usually an epidural spinal goes into a different space and provides a little bit different pain relief, especially if you would be going to a C-section. But we don't want to give opioids or like the fentanyl, because that can really depress the baby's respiratory system. We also don't necessarily are not able to do an epidural as we get to that 8 centimeter mark, depending on what's going on. That would be up to the mother and the anesthesiologist to determine. And then things that can assist with delivery, because sometimes the baby might get stuck if it's a big baby, or we talked about any of those 5 Ps, the passage, if that is difficult. And so sometimes an amniotomy is where the healthcare provider here will break the amniotic sac. So we said that oftentimes rupture of membranes, the amniotic sac is broken, and the amniotic fluid comes out. The body still continues to make it, but it just isn't contained, and so the baby's not kind of floating around in the uterus. And so sometimes that will actually help. If the provider breaks the bag of waters, then that will help the baby drop down into the pelvis and engage in the pelvis. So sometimes that's something that will help. There is something called augmentation of labor. So for the woman that's in labor, but we call it stalling, or they kind of aren't progressing, we will give them something called Pitocin, which is oxytocin, which I've had and I don't like it. The contractions just are so strong and painful. And then there's also something called induction, which is where we need to have the baby delivered. Maybe the mother is a gestational diabetic. We talked about that last week, and the baby might tend to be bigger, and so we want to induce. Say at 38 weeks. And so we will give some medication to help the cervix start to open up and thin in a face. And we can also then, once that gets to a certain point, then we can also start to administer the oxytocin to start some contractions going. Me personally, I think you let nature take its course as long as you can. I think the body knows what it's supposed to do. But having said that, I've seen times when the body doesn't know what it's supposed to do. And so medical professionals do have to kind of step in and help things along. There is something called, as we're getting ready for the baby to actually be born, like the head is on the perineum. You can see the head, generally speaking. So like this is a picture here of an episiotomy. And so the head is here, but the baby a lot of times starts to come out and then will get sucked back in when the contraction stops. We call that turtling. It's kind of like a turtle. They stick their head out and then they go back in their shell. And so what the healthcare provider will do is to make an incision. They can either make it down the middle or on the sides, where they'll actually cut to make the opening a little bit bigger, wider, so that the head can come out. What we have found with research and evidence-based practice is that we're not seeing as many episiotomies because, although it sounds counterintuitive, to actually let the woman tear, to tear here, it tears the muscle if it goes deep enough. But the body tears along the line that it wants to tear to let the baby out. We, the healthcare provider, not me, but the healthcare provider is not deciding, oh, I'm going to cut here or here and hope that helps. We're just letting the body do what it naturally needs to do. But that is an incision. It does need to be sewn up and watched for signs and symptoms of infection. There's also things that can help with if the baby's a little bit stuck or having difficulty coming out. I don't see forceps much anymore. Forceps are like tongs that you put on the side and kind of help to lift the baby out. You can see here, it can cause bruising. It could cause bleeding. I have only seen, well, that's not true. Yes, it is true. I've only seen one physician, one obstetrician in my time, who was adept, who was very good at forceps. Like if you were going to need a forceps delivery, he's the one that you wanted to do it because he was so skilled. It was amazing. Those babies, it came out just fine. But usually what happens is they will do what's called a vacuum assisted birth. So you heard me right, vacuum. So this is a little suction cup that goes on top of the presenting part. So this is the head here. And so the suction will go suction cup will go there, and it is the who's ever assisting with the delivery, then it's a pump, and you actually have to pump to get the suction. There's a little gauge, and you pump it up. So it's not motorized that I know of. There might be some motorized ones, but you get 3 tries to do that. And hopefully what that does is pull the baby just under the pelvic bone so that then the rest of the baby can be born. And so again, problems that you can have are hematomas. You can have what's called caput, which is where there's fluid there, you get some molding. And so the baby really needs to be monitored. If none of that works, then we're off to a cesarean section where they will do surgery. So I believe on the next slide is a picture of that. So just be prepared for that. Yep, there we go. So there are different emergencies that can happen. You don't really have to focus on these. I just wanted to bring them to your attention, just so you knew that there can be difficult times as well. So one thing is called a prolapse cord. So remember we said the umbilical cord attaches the baby to the placenta, which is attached to the uterus. That's how the baby breathes and eats. And so if this cord comes first, instead of the head, the baby's head, then it gets squished and the baby can't breathe or get nutrients. And so what happens is we actually see they have monitors that they put on to listen to the baby's heart rate, and also a monitor on the uterus to track the contractions. It will tell us how strong and efficient the contractions are. And so if we start to see the baby's heart rate dropping, usually it's like 120 to 160. If it starts to drop low, then this could be a reason. And we're not going to go into the whole mnemonics and all of that, but just so you know, that's a problem. What you do is whoever finds it is the lucky person that gets to call the emergency and take their gloved hand and put their hand there so that the cord does not continue, nor does the baby continue to come out. That is an immediate emergency C-section. You can also have what's called meconium-stained amniotic fluid, which is a sign of fetal distress. And so that's kind of what these pictures are showing. The baby actually poops in utero, which is a sign of distress again. And so what happens is when the baby's coming out, once the head comes out, a lot of times when the baby cries, right? That's one of the first things the baby does when it's born. We want the baby to cry to open up the lungs, right? So that the baby can breathe. But sometimes they can swallow that or actually breathe it in. Swallowing it would be okay. That would go into the stomach, but they breathe it into their lungs. And then that's a problem. We can take care of that. It's just a problem. So we want to be on the lookout for that. Dystocia means a lot of times it's a shoulder dystocia, probably mostly a shoulder dystocia, where when the baby's coming out, I don't know if you can maybe see it here. This isn't a dystocia, but the shoulder would be coming out first. And it's almost like getting a dislocated shoulder during the birth process. Precipitous labor, that's a labor that happens quickly. So, and unexpectedly. So not like labor took 2 or 3 hours, but like, for example, they come to the hospital and they're like in the wheelchair, they've wheeled her to your unit and the head is already out and you're like, and so like we haven't even set up for anything. And so that's precipitous. That means that also the baby's gone through very quickly through the passage and could have bruising, which has other repercussions later on after they're born. Uterine rupture. So this one's really scary. You can have a case where the uterus actually ruptures, tears, explodes, bursts, whatever you want to say. And so that is not a good thing. So that's a little different than what we call an abruption, which is where the placenta starts to move away from it. It's detaching from the uterus too soon before the baby's born. A uterine rupture is where the uterus actually, like, I don't want to say explodes, but bursts. And that's not good. And then you can also have, for the mother, what's called an amniotic fluid embolism. And so this is a C-section, but this is the amniotic fluid there in the sac, and sometimes that can end up in the lungs. It gets it because it's all the circulation's all connected, and so sometimes you can get amniotic fluid, and that's kind of a dangerous situation as well. Mom will end up in the ICU. Pretty good outcomes for that, as far as I know. All right, more graphic pictures. Sorry, probably grossing you out with this. And so this is actually a placenta, right? And so we said that stage 3 was from the birth to the placenta being delivered. Excuse me. And so I generally, maybe 10, 15 minutes, depending. Oftentimes I will see the providers pulling on the umbilical cord, which I don't particularly like because yeah, I think it's too much pressure. The cord can break, and then the placenta may or may not come out, might get stuck. And so you'll see that depending on where the placenta has been, that it will come out. There we go. Lots of blood. Yeah, if you're going to be a healthcare professional, usually there's blood. And so what they do is they call it Shiny Schultz, the Schultz presentation, or the Dirty Duncan. That's how we learned it. And so remember that the cord here, this is a nice insertion right in the middle of the placenta. And so this is the baby side. So and then this is the side here that was embedded into the uterus. And so that's the dirty side, because it was all like enmeshed into the uterus. This side here, the shiny side, is the part that's going to the baby. And the other thing that's interesting is that, I don't know, interesting, but sometimes the placenta can break into pieces. And so you have what's called retained placental fragments. And so which can affect breastfeeding, can be painful, some other signs and symptoms. But oftentimes the healthcare provider will actually go in and kind of scrape out, make sure all the placental pieces have come out. Sometimes if the mom is bleeding, that's in the complications one, that you're going to go in because there could be retained placental fragments, or find if there's a tear or something happening in there. So those would be emergencies. And at this point, the post-vaginal assessment begins. That's when the nurse, midwife, doula will start to perform their assessment to make sure that mom and baby are safe. Some places, if you're in a hospital, have a nurse for mom and a nurse for baby. Other places, it's the one nurse taking care of mom and baby. It just kind of depends on the situation. And so stage 4, this is by the viral signs, the vital signs returning to homeostasis, right? The body's kind of going, oh, all right, I'm done having the baby. Let's kind of try to get it back together. And so skin to skin is really important, doing skin to skin, having a nice warm blanket. The lochia, which is what we call the bleeding, because that's what's been inside the uterus is still coming out. We call that lochia. And so there can be bleeding. We watch that very carefully. Pain management. So IV or oral medication. We are still giving that oxytocin to help with contractions to get the uterus to contract back to its pre-pregnancy size eventually, and to stop hemorrhaging and bleeding. And you can also do topical medications for any swelling, things like that, or hemorrhoids. There's hemorrhoid medication, that kind of thing. And so that's a wrap. What you need to know for the quiz would be these things, which are your objectives. Yay. So let me go ahead and end that slideshow. Hopefully that wasn't too gross for you. There is also a PowerPoint on the complications with pregnancy. I'm not going to cover that because that's not really, I mean, I guess it's a focus. Let me look at it real quick and just give you the lowdown. Otherwise, we'll be here for 3 hours and nobody wants that. Hopefully this one will open up a little quicker. If not, we can, yeah, let's go ahead and download that one. That seems to work faster. And again, this is a shout out to my my colleague for allowing me to use this. And so different emotional responses and the support people, that's kind of what we'd be looking at when we have problems. So just knowing in general, not the specifics, right? So you've heard of hypertension. People have hypertension. Lots of people have hypertension. You can also have hypertension in pregnancy. And so you can already have chronic hypertension and become pregnant. You can get hypertension just when you're pregnant. And then it moves into what's called preeclampsia, where there's different factors there, which can lead to seizures and is not a good thing. So again, mostly this is just for your information, so you know that there are complications. And so this would be gestational hypertension. It gives you the guidelines there that you don't need to know. Any complications that you can have based on having hypertension. And so if you think of, well, I have high pressure in my blood circulation that's going on, then there can be all these problems that happen. Then there is preeclampsia with severe features, meaning that the blood pressure is really high, and there's pain, there's vision changes, there might be headaches, shortness of breath, and that can really, and swelling, lots of swelling, and protein in the urine or low urine output. And that's really bad. That can really be a problem. And so oftentimes what they'll want to do is deliver the baby by a C-section. They will monitor the mom for a while, see kind of how things go, give her some antihypertensive, some medications to help lower the blood pressure. And then if the mother then has a seizure, then that's called eclampsia. And that generally, once the mom is fairly stable or not, will go to an emergency C-section. And then to understand that with hypertension, with preeclampsia, you still are at risk to have high blood pressure after you've had the baby. And so to really be looking for signs and symptoms to call the doctor about. We talked already a little bit about postpartum hemorrhage. So blood loss that exceeds 500 for a vaginal birth or 1,000 for a cesarean birth. There are new guidelines that came out, and I can't off the top of my head. I looked for them, I couldn't find them. But you don't need to know that. Just know if there's a lot of blood and it's not stopping, that's not good. And so you can also have that bleeding during the postpartum period, not just right initially following the birth. And so this kind of shows you, we called it lochia, right? The bleeding, the blood that's coming out of the uterus after the baby's born. And these are just examples of if you're saturated, that's not good in 1 hour. And so they actually will weigh the pads. It's like a menstrual pad, and they'll weigh them to estimate the blood loss. And so what we want to do, the first thing that for nurses anyway in there, it could be a family member that's noticing the bleeding, but massage the fundus. That's always the first thing. Massage the fundus and then try to figure out where the bleeding is coming from. We want a firm fundus, which is the top part of the uterus right there. And then limit activity, maybe some vitamin supplements. The prenatal vitamins are good. And then preterm labor. So the baby decides they want to come early, like my first son, who was a 32-weeker, doing fine, 33 now. So preterm labor, there are different things, different medications. We kind of want to try and stop that if at all possible, if it's going to be dangerous, but sometimes the body just doesn't let you do that. And so we have a baby early. And so that's a wrap. We want to write complications. So what way can complications affect the growth and development? So if it's a preterm baby, that can affect growth and development because the baby's early. The parents aren't quite prepared probably for that. And what do the support partners do? Your support people. A lot of times they have opinions. So hopefully, I think it's good to set boundaries prior to that. The other thing that's a big complication during pregnancy, besides the hypertension, is gestational diabetes. So diabetes that you get, I think I went over that in the prenatal um, prenatal care, but that's another problem. And the moms tend to have bigger babies. Alrighty, so cultural beliefs and practices. So these are just different articles that talk about cultural aspects of childbirth and beliefs and practices around the world. So take a look at those. And then the activity, let me do the journal first, sorry, and then we'll go back to the activity because we're gonna go to another website for that. Is, what was your birth experience? Have you given birth or watched somebody give birth? If you're not, what did you get out of the lesson? What do you think about that? How can you, would you look forward to it as a support person? What do you think you could do? And then what have you learned about how the birth experience could affect growth and development from the parent's perspective as well as the baby? So how could it affect mom, dad, and the baby as well? Okay, activity assignment. So we are going to do what's called a Padlet. It's kind of like a discussion board, but I think it's a little, well, of course I do because I gave you the assignment, but I think it's kind of fun. And so what you're going to do is you are going to, we're exploring cultural practices. And so you want to explore and research different areas or cultures using reputable resources to find anything in childbirth, postpartum, or the newborn. So it could be the infant. So any of the things that we're talking about this week, any particular cultural or spiritual religious practices or taboos. Taboos meaning things that we don't want to do, or things that we don't want to do. So for your initial post, you're going to go to the Padlet map. I'm going to show you how to get there. There's a link there. This is what your initial post would look like. This is actually my practice one that I put up for you so you can see it. And you click on the little plus sign to add yours. And you are going to click on the geographic area. I'll go to the map and show you that you researched and write a post that talks about your thoughts on how the practice or the taboo might affect growth and development. At least 5 sentences, please. And please, please, please include your name. You do not have to sign up for Padlet. There's no cost anyway, but you need to put your name in there because if you're anonymous, I don't know who you are and I can't give you credit for your answer. And then you need to respond to at least one peer supporting or asking questions from their discussion, what they showed. So try not to duplicate each other's, but if you do, I guess that's okay. And so you can like a post, you can click on the little heart down here, and you can leave a response by clicking on the little speech bubble there. And then the rubric is here, what you need to have for your initial post, your response to the one peer. They're both worth 5 points. So let's go to the map. And I have to make it, I don't know why it keeps being the big one, probably because that's where my little marker is. Yep, there's Iceland. Come on, country, world. There we go. Right, and so this is my little pin. They call it a pin. And so I put my pin there. And then for this Padlet, I wrote, this tells you what you're supposed to do. And then if you click here, this will actually take you to the post that has to do with, oops, that's not what I wanted to do. Sorry. Right, and there is my example, talks about, I copied and pasted it. Don't copy and paste, write your own words. But it shows you, there we go. That's the post. And so if you wanted to respond to me, you would click on the little speech bubble. If you wanted to like it, you would click the little heart. And then this actually, the picture takes you to the website that where I got my information. And so you do need to include your reference, I believe. Your name. Yeah, and provide a link to your resources. And that's how that works. So I always think that's kind of fun because you can be anywhere. So what you want to do, move that out of the way, is there's your little plus. And so if you click on the little plus, drag and drop the pin, or you can search a place and you just drag and drop the pin someplace, wherever someplace in Canada. I don't know. And then it'll ask you, are you in Saskatchewan? It'll give you some options there. Or like I said, you can uh, put in where, if it was Saskatchewan, you could spell that and put it in there. And then it went away because I don't want to do that. Okay. And that does open up in another window. So you're good there. And that's that. So have fun with that. Hopefully that doesn't take too long. It's often one that I, excuse me, do in class with my students. And I think they usually have fun with that. That link takes you to the same place. And so let's keep moving on. I think birth and infancy are the longest things to look at. We'll go to, so we did Padlet, we'll go to the postpartum period. And so looking at the recovery process, postpartum complications, we already talked a little bit about those, checkups, and ongoing medical care for new mothers. We talked about that for prenatal visits. Now we're going to talk about it for postpartum visits. How do you get people to go? Do they have access to get someplace wherever they need to be seen? What different emotions, things like that. We're going to focus on postpartum depression, baby blues, and then looking at support services, things that are support. You have recordings already for the depression and the complications. So I will let you look at those at your own time. And then the postpartum PowerPoint is there. Hopefully that will open up. If not, we will just keep downloading. It does open up. It's just not doing it fast enough for me because I would like to try and get through this. I know this one was going to take a little bit longer than usual. And again, thank you to my my colleague for allowing me to use her information. So we've had the baby. We're stage 4. We're actually past stage 4 now because we've gone through that initial recovery period. And so we are postpartum. And what do we do now? And so physical recovery, breastfeeding, new challenges are kind of what's covered in this particular PowerPoint. And so getting a little mommy time there. There's the umbilical cord. But this is a time where shock, infection, hemorrhage, there's high risk for those things. So we kind of already talked about some of the things that would happen. And pregnancy, childbirth affects the entire body. I don't expect you to necessarily know these specific changes, just that there are changes. These are the hormonal changes that occur that lead us to be able to make milk and feed our baby, lactation. And so tells you about the levels of the hormones. And then the hospitals in our county are all baby friendly. I know some of them have had the baby friendly certification renewal coming up. And as far as I know, everybody's passed theirs, been approved again. So that's good. It's supposed to help support moms and educate staff and encourage breastfeeding. Breastfeeding is a personal choice. I will disclose that I have been an international board certified lactation consultant. I did not renew my certification, mostly because I'm not practicing in the hospital anymore. I do have a home visit business, but I opted to get my certification as a nurse educator. I felt like I would use that more, but I do still have a lot of education and experience with breastfeeding. So it's kind of one of the things that I'm interested in. And so there are 10 steps, and you need to explain. The staff all has to be educated, and we're not going to hopefully provide pacifiers too soon. And try to do the breastfeeding and breast massage and colostrum and encourage as much as we can to provide colostrum and breast milk. So colostrum is the first, the precursor to the actual breast milk. But we're not going to go into that whole scenario quite yet. Postpartum. So this is what the nurse would do in terms of the assessment. And we use a little acronym: bubble, breast, uterus, bowel, bladder, lochia. If there was an episiotomy, we also check the epidural site, emotional status. Those are things that we check with mom. And then on baby, it's so cute. Hello, baby. We want to make sure that the mom is warm, that the baby's warm. That's why we do the skin to skin, There's evidence that it helps regulate postpartum mom and baby's vital signs and temperature. And so warm blankets are good. The fundus. So we check the fundus. Remember, we want that to be firm so there's not bleeding. So this shows you kind of how it's supposed to, we call it involute, go back to its pre-pregnancy state. We talked about the lochia, that we're watching for hemorrhage. There's different kinds. It eventually will become sort of yellowish white after about 10 days. The cervix and the vagina, this talks about different, when we talk about tears, it shows you the different degrees, how deep or far in that it goes, how far down the perineum and how deep it goes. Don't expect you to know that. Just know that that's a complication. And then the breast. So this tells you it's colostrum initially. This shows you the milk ducts, the size of the milk ducts. And the milk isn't produced really, it doesn't really transition from the colostrum to the actual breast milk for about 3 to 5 days. And so a lot of times if we haven't done our education correctly, or maybe cultural differences, ideas that a lot of times the mothers will tell us, we don't have any milk. No, but you have colostrum, which is the precursor and has so many immunoglobulins and vitamins and so many good things for the baby there, that if we can get the baby colostrum, that's great. And so the more the baby's at breast, the more skin to skin, it all gets that hormonal cascade going. The minute we introduce a bottle, then that's a barrier. And can interrupt milk production, especially further on down the line. So we have lactation consultants in the hospital that actually will help the mom. They do the inpatient visits usually during the morning, and then they'll do outpatient visits in the afternoon. There's usually a like a warm line you can call and get coaching on the phone if needed. I've done that as well. Talks about our cardiovascular system. It just goes through the different changes of each system. We also want to make sure that the immunizations for mom are up to date. So which one do we usually, we'll do Rogam. We'll give after they've had the baby. Varicella, sometimes they haven't had their MMR, so we give a lot of MMRs and Tdaps. Which you will learn about those in the coming weeks. Comfort, whatever it takes to feel comfortable. I love the little inflatable donuts. Sitz baths are great to help the perineum, put warm water in there and soak the perineum. Tux pads, there's also a spray that you can use to help with swelling, which is good. And then being able to adapt. So this is psychosocial. So it's, you can be all prepared that you think you are, and then baby comes and you're like, even on a second or third or more baby. And so the like you're in the first like day or two, you're like taking everything in. You're like watching and kind of experiencing and feeling what it's like to be a mom and with the baby, and how is my life changing, and like no sleep, that kind of thing. And so when you are trying to do any education at that point, it's very difficult because I'm not I don't want to hear about it right now. I'm bonding with my baby and I'm learning how my body's changing and I'm taking everything in. And I'm very dependent. I need some help um, with those things. But culturally, sometimes that's not uh, seen as a good thing to ask for help. So you need to keep an eye on that. Um, you then, after 2 to 3 days, you become a little more independent, and they call that the taking hold phase. So, okay, I got this. I've taken it in. I got it. Okay, I'm good, and or maybe not, but I get it. Okay, I've got a baby. These are some things I need to do. This is where my body's at physically, where I am emotionally. And I'm becoming somewhat independent. I'm not as dependent. And so that's called the taking hold phase. So if a mother delivers vaginally, she's probably only in the hospital for that 48 hours. Insurance doesn't usually pay for longer than that. And so if they're being discharged home on that second day, they may or may not hear a darn thing that the healthcare provider professional is trying to even tell them. So we give them lots of handouts and online resources and phone numbers to call. If it's a C-section, they're generally there for that third day. And so they may be a little more willing to hear things. Interdependent, the letting go phase, the focus now is on the family and resumption of the role. You've gotten over the birth thing. I'm ready to go home, or I am already home. And all right, I'm going to figure out how this works now that I'm home and not in the hospital. And so those are, there's research that accompanies all those stages. Interestingly enough, there's also paternal adaptation stages. And so a lot of times the dad will do skin to skin with the baby. Now, that doesn't necessarily mean, I mean, it helps with the bonding. Skin to skin helps regulate baby's temperature and vital signs. But it's great. I remember the first time I saw a dad do skin to skin. It was a C-section, and he came in to the nursery with the baby, and we had gotten the baby cleaned up and diapered and everything like that. And I don't even know if we had put the diaper on yet. And he just ripped off his shirt. He just pulled his shirt off, like, okay, where can I sit and do skin to skin? Like, he was so ready to do skin to skin. It was so cute. And so dad will be bonding with the baby as well. But then you have your siblings. You have those, there can be only one, vying for attention. So depending on the age of the siblings, to be able to prepare them for baby coming home, and that the attention is going to be divided now, which can be difficult. So if you can, include the sibling in the care, like have them hold the diaper until you're ready to put it on. Like they can hand you the diaper, they could hand you the wipes, they could help with different things like that. Get baby the binky or a blankie, or help read to them or something like that. Not put boards on top of them. But the other thing you could do is, a lot of times you'll see the t-shirts, I'm the big sibling or something like that. So anything to promote positivity with the sibling is a good idea. And then I told you what slides you would need to know are important to know there. All right. Everybody's probably overloaded at this point, but hopefully what you do is you take one section at a time and then move to the next one. So this particular video, I'm not going to play it. Y'all can watch it on your own, but it is when you talk about postpartum depression and it gets really, really bad, and maybe you're in postpartum psychosis, suicide becomes an option. And so this dad, after his wife committed suicide after having their baby, it's about his mission to help women overcome that. So it can be kind of emotional. Postpartum care guidelines, if you're interested in those. The recovery guide, how long it takes to recover. So we don't just, the baby comes out and we're fine in a couple of days. It really takes a while. The postpartum check traditionally has been at 6 weeks. Well, the guidelines now say it should be sort of like a 12-month ongoing support thing. So they kind of want to do a visit initially after a week or two, and then and then do a schedule after that, maybe at 3 or 6 months, and then continuing on for support to check for mental health, things like that. And so this is just sort of a little timeline about that. There are more ideas about cultural practices around the world, and our weekly journal. So postpartum care, barriers to postpartum care. Is there some way that socioeconomic status might affect that? How could you help someone overcome those barriers? And then your activity for postpartum considerations in the child rearing family, because now we're child rearing, we're taking care of our kids. And so there is a case study that you get to choose. So let me walk you through this. And this is due on the 21st. So you have 2 weeks to do this particular one, as well as the infancy one. The Padlet is due in the 1 week time frame. And so we're trying to understand, this looks kind of like social determinants of health, but not really, but physical, emotional, cultural, socioeconomic considerations during postpartum period, to try and help them develop strategies to be effective parents. And so hopefully you will gain a deeper understanding of considerations during the postpartum period and be able to help, support families through that. And so go back and look at the lesson that we just reviewed, the lesson. And you can also look for information, again, from reputable internet sources or the Hartnell College Library, which is over here on the left-hand side. And then the first thing you're going to do is select a case study. So choose one of the following case studies, or you can make up your own, but choose one of the case studies. A first-time mom with significant postpartum depression, struggling with breastfeeding, a premature infant, a mother recovering from a C-section. So if you click on the case study, that little link there, it will take you to the case study and give you the information. And then just click your back arrow and it will take you back to the assignment, right? So you decide which one you want. And then you're going to analyze it. So what are the key physical, emotional, cultural, spiritual issues presented in the case study and the impact of those on the family's well-being and functioning? So if we are doing case study 3, the mom recovering from the C-section, all those things, the physical, emotional, those things are all in the case study. So you kind of want to put them in your own words and then go deeper into how that's going to affect the family. So if Emily's experiencing significant pain and limited mobility, so what does that mean? What does that mean for support people? Does she have support people? Is dad involved? Like if she can't move, she's in a lot of pain, how does that affect everybody else? What is the effect on the baby if she's having difficulty caring for the baby? So that's part of the analysis. And then you want to propose strategies to address those issues. So consider interventions from healthcare professionals, community resources, family support systems, and the role of healthcare providers, healthcare professionals in supporting, it should probably be healthcare professionals because it should be us, in supporting the family through the postpartum period, right? So you're going to think about that. So if she's having pain, what can we do about that? If she's struggling with certain things, what resources do we have? What resources do we have in Salinas Valley or South County or North County, or what, what do we have available here? And so you're going to submit your case study analysis and your support strategy. So it tells you right here what you need to put in your introduction. This is what goes in the introduction. This would be each section, right? So it tells you what to include in each section. Put it in your own words, please. Don't just copy and paste it. And then in the conclusion, it tells you what to put into the conclusion. So this information is in the case study. You shouldn't necessarily have to make it up. Where you're going to have to do your research is for the support strategies. What do you think would be helpful? Okay, so if you follow that, that's what your paper should look like. So let's see, conclusion, we did that. So submit the following. Submit your case study analysis, right, which is this introduction, sections, and conclusion, right? And then the format, APA is preferred, but don't worry about it. Just write it. It's okay. But you need to have at least 2 references, one from the lesson and one from some research source that you got yourself from the internet or the library. 12-point font, 1-inch margins would be great. At least 500. You can go more than 2,000, but you don't have to. It has to be at least 500, which you should have way more than 500 if you go through and answer all of these questions in some detail. And then here is your rubric. The majority of the points, right? Only 2 points for the formatting. So the 8 points is really the meat of what it is, so that you cover everything. Everything's covered, right? The introduction, the sections, and the conclusion. Okay. And each section, each one of these numbers should probably be a separate paragraph. That would be helpful for me in reading that. So hopefully that that makes sense. And again, you have 2 weeks to work on that. And let's go back to modules because we still have one more section. Yeah, there's going to be more information in these coming weeks. So I'm sorry that this takes so long, but again, we are covering 3 hours worth of a lecture where we face to face. So we've got that, and then what else? All right, so we are on to infancy. So we're going to start with infancy, and then in week 6, we're going to move on to early and middle childhood, adolescence, and then in week 7, early, middle, late adulthood, and then week 8 will be grief, loss, death, and dying experience. So this is where we are going to start to, which I think we've done already. You've done that already, prenatal and birth experience. Take in those social determinants of health. Take in our developmental theorist frameworks, Erikson, Piaget, those kind of things. So now that you have that foundation, now we're going to build on it as we move through the actual developmental stages in more detail. So main characteristics of the infant, looking at fine motor being fine, like drawing, writing, holding things, gross motor being big arm movements, walking, crawling, things like that, gross motor. Nutritional needs, advantages, disadvantages of breastfeeding and formula feeding, and basic needs of the newborn, like basic care of the newborn. And so here are the chapters. Again, they're very similar. Choose the one that works best for your learning. There's a little bit of different information in each one, but they're pretty much the same. And there is your activity assignment, which we will come back to. And then here is your lesson. So there is the PowerPoint. Yes, it's from 2020, but everything's still relevant. Infant care basics, how to care for an infant, infant nutrition. Again, y'all can go through this on your own. There's feeding your baby formula, how to prepare formula, because that's really important. Some people don't know how to do that safely. Benefits of breastfeeding, Bright Futures nutritional guide. So we're going to use this through several of these stages where Bright Futures talks about the guidelines for each stage of development. What's in breast milk? What does the breastfeeding mom need to eat, right? At least 300 to 500 calories, but what kind of calories? Like what is the nutrition there? And then some different tips from University of California, San Francisco. They are a leading resource, Benioff Children's Hospital. Like their neonatologists, their doctors, their pediatricians, OBs are just amazing. And we use at Natividad, especially in CHOMP, their standards of care. And we talk about lactation consultants, how we can help you breastfeed, how to become a lactation consultant, because there's different levels of lactation consulting. And then I will go back to the PowerPoint. I'm just showing you the other things in the lesson right now. So we look at the CDC, Center for Disease Control, CDC, and I don't know why sometimes, but that's just, I'll get off my soapbox. But they have what are called milestones, developmental milestones pages. And I've given you links to the 2, 4, 6, 9, 12, as well as the 15, 18 month ones. If we know what is normal development or considered normal development, then if there are issues as healthcare providers, we can bring those forward and say, hey, maybe we need some more screening for this or that or the next thing. The baby's not talking when we thought they should start talking, or walking or moving, or grasping things when we think, or they're crying all the time and we can't console them, things like that. And so if you go to the developmental milestones page, it will actually take you to each of these months, and you can look and see what are the milestones, developmental milestones, and your activity is going to be having to do with these. And so it tells you what most babies do by this certain age, right? They'll calm down, they'll look at your face, they'll make sounds, things like that, babbling. And so each one of those, like, it has pictures, it has little video clips, holds their head up when they're on their tummy. Tummy time is important because we do back to sleep, and then we want them on their stomach as well. And so each one of those gives you milestones. You don't have to memorize them. If you, when you get into the nursing program or other fields that you're in and have to deal with children, it will be a good idea or required to know those more in depth. But for right now, just know that there are differences. And there's actually an app, because there's an app for everything that you can install, and it will actually, on your phone, you can look things up, which is really kind of cool. You can also go to the Bright Futures resources. We talked about their nutritional guide, but they have a whole materials and tools, families, right, that you can use. That's usually the good place to go, is families. And it talks about, well, they charge you for the materials and tools, so I don't really like that. But but this is from the American Academy of Pediatrics, so it is a good reputable source for you. And that's why I like to use their nutritional guide. And then there's also something called the Ages and Stages questionnaires. So when you will take, let's say I've had a baby, it's the 2-month checkup, and I am getting ready to go to the pediatrician visit, the clinic visit, my pediatrician, wherever I'm going for my 2-month visit. I've looked up on my milestones tracker what the 2-month-old is supposed to be doing, so I'm good. We're doing most of those things. But what the provider will probably have you do, and it could be the Ages and Stages, ASQ, and I may have to update that because I think we're on the ASQ3 now. So I'll go back and take a look at that. But they have, oh, yes, I did. It says ASQ2, but it's the ASQ3. I thought I updated that. And so this is a questionnaire that the parent fills out. And so it asks different questions. So different notes that you can take, because we can ask these questions and they will at the visit, but if the parent can fill it out ahead of time, I think it's easier, because then I can say, here, I filled this out and this is what's, or have it as notes or something. So does the baby gurgle? Do they coo? Do they make sounds back to you? Do they smile when you talk to them? Do they kind of laugh a little bit? If you've been gone for a little bit, did the baby get excited when you come back? The gross motor, so that's communication, gross motor. Does he hold the head up? When they're on their back, do they kick their legs, right? So you just kind of go down the questionnaire. Will they grasp your finger? Do they hold it in their hand briefly? So can the baby see things or look for things that are 8 to 10 inches away? What's 8 to 10 inches? I don't know. Take your best guess. does the baby track the toy or reach for the toy? So this thing, I mean, it's like 6 pages long. And so you go through everything. Did your baby pass the newborn hearing screen? That's in the PowerPoint, I think. Did they move both hands and legs equally well? Right. And so they're just asking you all these questions. And then you and the provider, or the provider and the parent, can sit down and talk about the results. And so depending on how they scored, there's a way to score everything. Are they progressing as we would expect them to progress or not? If they are not, then there are referrals that can be made, or we may say, hey, let's keep track of this and this and come back in 2 months and we'll talk about it again. And so you have those through 12 months. This talks about language development, which actually ties a little bit in with different, like Skinner, we talked about operant and classical conditioning, and Vygotsky is in there, talks about that a little. So we're bringing those theories back into play. And then just different topics that might be of interest or that you might run into as a healthcare professional dealing with working with infants and their parents. So sudden infant death syndrome, which is now known as a subset of sudden unexpected infant death. So SUID, SIDS is a subset under that. And so I provided you with some different articles. There was a study a couple years back that found the cause. Maybe, maybe not. I think that might be where the sudden unexpected infant death category came from. Safe sleep. So back to sleep, right? The baby goes to sleep on their back. That's why we do tummy time when they're awake. And then the different screenings that happen. So one of those questions on the 2-month questionnaire was, did the baby pass the hearing screen? And so we do a hearing screen. I was actually the director for the newborn hearing screen program when I was at CHOMP. And so every baby gets screened unless the family declines, parents decline. It's non-invasive. It is just a screening. These are all just screenings. So if there are results that are questionable, then there's always follow-up. So for example, for a hearing screen, that's done before the baby's discharged. And it plays, they put little ear covers on, and the machine plays patterns of clicking noises. And the machine, there's little tabs that go at different places on the baby, 3 tabs, and picks up the brainstem response to the patterns of the clicks. And so different things can affect that. And so sometimes both ears pass, great, no problem. Sometimes one ear passes and one ear doesn't. Sometimes both don't pass. And so if one of the ears or both don't pass, they will do the screening one more time before discharge. Baby passes, then we're good. If the baby doesn't, then the baby will come back one time for as an outpatient. So they give them about a week or 2 and then have them come back. There could be something in the ear that then, from the birth process that then, has been cleaned out at that point. If the baby does not pass during that outpatient screening, then they get referred to the county hearing center for more in-depth screening and testing. And so we had maybe, this is years ago, but I want to say at least one baby a year that actually had a diagnosed hearing problem. So we probably had maybe 10 per month that would have to come in for an outpatient screening, and maybe 1 or 2 of those would go for further testing. But of those, only about 1, I think there was 1 year we had 2, but 1 had an actual hearing loss. The other thing that happens is the newborn screening. It used to be called the PKU, phenylketonuria. It does still test for that, but the website will take you and show you, there's like 30, 40, there might even be up to 50 or 60 now, different metabolic disorders that can be diagnosed. Many of them have a genetic component. And so that's why we looked at genetics previously, because now we'll come back around and there will be tests done. They'll also test that has a test for cystic fibrosis. And so we can hopefully learn about those things as early as possible so that we can provide interventions for that. Car seat safety, always check your laws because they change in every state. They change every so often. And then the immunization schedules. So this is 0 to 18 years for 2024. They change every year. I am not asking you to memorize these. Just know they need vaccines. Um, there's RSV now that's just come out, not just come out, but it's been around in different forms for a while, but now it's on the schedule, the hepatitis B, rotavirus, the DTaP, a little different than the Tdap. The formula changes a little bit as we get older. Pneumococcal, polio, COVID now, flu is there, MMR, varicella, which is like chickenpox. They now have Hep A, HPV, human papillomavirus, the meningococcal series. There's another RSV one. Dengue and monkeypox are not on there. It should not, I mean, I don't, that's for if you're like traveling somewhere. So you don't need those. Couple different sites you can go to look at different immunization schedules. Immunize.org has some good resources in terms of actually how to administer the vaccines. And then your journal for infancy. Interesting piece of information you learned. Where do you stand on vaccines and immunizations? What are your thoughts on that? And that's why it's in your journal and not in a discussion post. So let's go back and look at the PowerPoint. I don't want to say quickly, fairly quickly. See if we can get that. Yeah, I'm going to do it this way. And I'll go back and change the format so it's like this on the other two as well. So this one is a long one. So I just want to cover, we've covered a lot already. And again, this is mostly a lot of your, for your edification, your learning, but not necessarily going to be tested. So the APGAR score, they give a score once the baby is born. How are they breathing? That way, there we go. Their respiratory rate, they look good. They're pink, they're crying, they've got tone, that's all good. If the baby's floppy and has a low heart rate, then there could be issues. So we're looking at that. That's kind of in that initial birth to postpartum time. So it gives you the scoring there. You do not need to know this information, but it gives you how the fetal circulation changes, right? Because our circulation is different than a fetus inside mom because of the placenta that's and the umbilical cord, and we're going through mom's circulatory system when we're a baby. And so it's important to know that there's a difference, but you don't need to know the specifics about that. So here are the physical characteristics. This is one of the objectives, but again, I don't feel like you need to know this. You don't need to memorize any of this. And so fontanelles, how big are babies? Different things on the skin, if they're jaundiced. So if there are those forceps deliveries or the vacuum deliveries and you get broken blood vessels, the baby's body can't soak those, the liver can't soak those back up. And so the bilirubin, which is a byproduct of the red blood cell breaking apart, is floating around in the body. And that's where the yellow skin color comes in. Acrocyanosis, that's a normal variation, should resolve fairly quickly. So here's talking about jaundice. So a lot of this is if you want to know about it, if you have questions or you've ever thought about it, different types of jaundice. This is how you treat it with the phototherapy. Some of you may have experienced this with your children, and so maybe this will give you a better understanding of that. More physical characteristics in terms of, hello, little cutie pie. Oh my goodness. The chin, the eyes. Here's talking about the abdomen and the size of the stomach based on, day 1, day 3, week 1, 1 month. Baby's tummy's tiny, doesn't need a whole lot to fill it up. And when you are feeding the baby, it also doesn't know when to stop because they're going to just keep sucking. So we have to sort of be the gatekeeper of how much is going in the stomach, which is why colostrum is so great, because that's about what you get with colostrum for the day. And so there's advantages for baby, advantages for mom, which is one of your objectives, disadvantages. There can be disadvantages. So galactosemia, that is a genetic condition that where the baby cannot even have breast milk because they can't break down the galactose. And so they have to be on a special formula for that. And then we actually go into some breastfeeding information, different positions, just, for your edification, nutrition. There's an article that I posted on when to start solid foods. These are good indicators, which is why it's good to know their gross motor skills and their fine motor skills. Are they able to start solids? Pee and poop. Gotta love pee and poop. Baby poop, different colors of baby poop. I actually have this poster in my office. How many wet diapers should the baby be having? What should it look like? Going into male and female genitalia, looking at circumcision. We want to make sure that the testicles are descended in the male, different female genitalia. So all physical characteristics. Reflexes are meant to be safety mechanisms. And so we've got the blink reflex, which keeps our eyes clean, the swallowing, sneezing, the gag reflex, so we don't choke on stuff. There's a startle reflex. That's a good indicator of neurological status on the baby. Rooting, sucking. We call the tonic neck reflex the fencing reflex because it looks like you're fencing. And being able to grasp with your toes and your fingers. The red reflex, we want to see red. If we see white, that's a problem. Either probably with the retina, but it could also be a sign of cancer. And then just some more reflexes there. Vital signs. Yes, we take vital signs on babies, not usually blood pressures, unless they're in the neonatal intensive care unit, but they're going to breathe faster. Their pulse is going to be faster. Want to keep them warm. Okay? They need to stay warm because if they stay warm, then their blood sugar will be good, hopefully, because we don't want them having low blood sugars because then that can lead to big problems. So that's why if it's a baby of a diabetic mom, that we're going to check the baby's blood sugar as well. And there are specific protocols. So bonding, again, with dads, we talked about the bonding. It's called engrossment. So there's another dad doing skin to skin there. We talked about the taking in, taking hold as part of the postpartum. So that's there as well. And the siblings we talked about. I love this little picture, right? There's dad and they had twins. And there's big brother. I think that's so cool. They're in the NICU. But I love that picture. Grandparents, sometimes they're a little overbearing. Try not to be. Culture, how does culture affect things? So my personal philosophy is with the culture, which is why we're having you do the Padlet on the culture as well, is that I can memorize a lot of different things. But I think our cultures are so enmeshed these days. I don't know if enmeshed is the right word, but there's so much crossover and diversity, I guess I would say, right? That just because you are a specific ethnic group or race or come from a certain place doesn't mean that you necessarily share all of those specific cultural beliefs. So I don't want to just assume that you want your water hot or you don't want ice in your water or you do want ice or not. And so I'll usually ask, would you like some tea? Or I'm going to get you some water. Would you like some ice? Things like that. Or ask them, is there anything you want me to let nutritional services know that you're allergic to or that you don't prefer not to eat? I think most of the hospitals, nope, I take that back. Well, maybe. Some provide a tray, some you can order what you want. So, and know that culture can affect the response to pain and to childbirth. And so again, so the neonate, more things about the baby. Again, this is more focusing on the baby, which is the infant, but this is like the beginning part. So how much sleep is there? Um, Cognitive and psychosocial theories. We talked about Piaget and the sensory motor, right? You learned about that, and that's how the infant is going to explore their world. And right, sensory motor. That's why we like lots of colors, and not overwhelming them, but when they're awake and alert is good. And then here's more developmental milestones as it goes along. The red was key points for quiz. I use this in another course as well. So that's what the red was, that the students needed to know. So it just kind of goes through, this is 4 months, 1, 2, 3, 4 months. So if you want to know, now you have it on the PowerPoint. 6 months. There we go. That should be like, oops, sorry, 9 months, right? It's pulling to stand. Now, understand that babies or people in general will go through the specific stages. Everybody, 99% of the time, goes through the same order of things, of milestones, but not at the same rate, right? So you're going to raise your head up first, and then you're going to kind of do this little army crawl thing, and then you'll kind of get up on your hands and knees, and then you'll sort of pull up to stand, and then you'll start to take your first step. Some babies will do that by 9 months. Some babies will do that by 13 or 14 months, but they will do it in the same order. So that's something to know about growth and development. So this just ran you through that, and that was that. So that was that. So now let's move on to, I'll see if I have an infant PowerPoint that's more like the 2, 4, 6 month one. I'll see if I can find that for you and add that on there. Oh, I went the wrong direction. Go the other way. Up. There we go. Sorry. Minimize, preview. There we go. And so the activity assignment, I do believe you have 2 weeks again to do this one. So we're kind of overlapping assignments so that you have some time for them. You can always do them early. That's not a problem. You don't always have to leave them until the due date. But hopefully that takes a little pressure off. So developmental screening tools. So we talked about the ages and stages. That was in there. And we looked at the CDC guidelines as well. So you're going to review the lesson on that and reflect on what our role as healthcare professionals would be in conducting the screenings, and if the child needed to be referred someplace. So what you're going to do is research and review the different developmental screening tools commonly used. So again, we talked about ages and stages, and we talked about the CDC milestones. But there are some other ones. There is the Denver Developmental Screening Test, and these links all take you to where you can see those developmental screening tests. There is the Pediatric Symptom Checker. There's also the MCHAT, which is a modified checklist for autism in toddlers. So that one is there as well. And so you're going to look at those, because what you're going to end up doing is comparing to compare and contrast 2 of them. So you're going to look at all of these and then choose 2 to research further to compare and contrast them. And to help you do that, you have these case studies for developmental screening tools. Yes, I guess you can see I like case studies. And so you want to be able to match the child with a screening tool. There are correct answers, but there's also a lot of leeway in them as well. So for example, let me show you case studies for the developmental screening tools. So if you click on that link, it will take you to the page. And I have a little example here. So it says, after deciding on which 2 screening tools you're going to compare and contrast, use these case studies. These here, I think there's five, three, four, should be five of them. Use these case studies to choose a child who would benefit from each screening tool. So for example, I chose the DDST, the Denver Developmental, and the Pediatric Symptom Checker, the PSC. So I need to think about, okay, if I'm going to look at the Denver, which one of these children am I going to use which one would be most appropriate for the Denver? So, the child with motor, so I have a child with a speech delay. I have a child with motor skill delay, looks like gross motor skill delay. I have a child with social and behavioral concerns. I also have a child with more emotional and behavioral concerns. They're a little bit older and some different concerns than the previous child. And then I have a child with just general developmental concerns. So if I am using the Denver, which child would benefit most from me using the Denver on them? So I think that case number 2, the child with motor delays, that the Denver would give me the most information about that. Hopefully this makes sense. And then for my child with emotional and behavioral concerns, for the pediatric symptom checker, so that's number 4. So I think looking at this case, I think the pediatric symptom checker might be the best. Now that's not to say that there are other ones that are better, but for example, this child is 7. And so my other child with social and behavioral concerns is 4. So if I'm going to use the MChat, this child who's younger may benefit more from that because we'd want to catch it sooner than later. So hopefully that makes sense, right? So you're going to research the screening tools. You're going to come here and try to match them. And again, there's multiple correct answers. So just choose based on what you think, because you're the healthcare professional that's going to be, you're not going to actually do a screening. Let me be clear. You are not doing a screening on somebody, but you are the healthcare professional who is choosing which screening tool to use on a particular child, if that makes sense. You do not have to do it. When I went to school, I'd actually do one. I did one on my nephew. That was fun and exciting. He was 4 at the time. So what you turn in, and there's also a little summary because I can be very verbose. So you're going to do a reflection paper, right? So your understanding, to showcase your understanding of the developmental screening tools and early identification of delays and challenges associated with the screenings. Because if I'm going to give the MChat, that might be kind of challenging. So what kind of environment would I need to have in order to conduct that screening? Right? So choose 2 screening tools, brief introduction that summarizes the key features about each tool. So here's a resource for you. You can use this as a resource as well as the links that you have above. So this one is comparing and contrasting developmental screening tools. When you see this, hopefully you say, thank you, Mrs. Solinger, but you don't have to. But it basically gives you each of the 5 that you're researching, tells you what they're designed for, the age ranges, what kind of format it comes in, what different domains, cognitive, physical, emotional, how you give it, how the scoring's interpreted, how specific it is, any follow-up actions, the setting that you might find it used in, and why you use it. And so, yeah, so there you go. So that basically will help you answer or do research on that particular tool. So then you're going to go to the case studies and find a child that you think matches to the tool. If you want to pick a case study and then choose a tool, that's fine too, whatever works for you. Just want you to be researching the different tools so you understand what they're looking for and when you would use them. And so for each tool, using those case studies, you're going to, what are the strengths, limitations, any challenges, further follow-up, what do you do if that's needed? what is the role of the healthcare professional in providing the screenings and communicating the results? Is it our job? If it is, then how do we do that? And then how early identification is important for the growth and development of the child, right? You do not have to perform the screening on a child. So I try to summarize here, right? Review the tools, choose to match the case study or find a case study and then 2 case studies and match tools. That's fine too. And then you're going to turn in a reflection paper that includes a summary of each tool. And then for each tool, summarize each strength, challenges, further follow up, those things. So hopefully that makes sense. So then if we look at the rubric, the formatting out of 10 points is worth 1 point. And so 2 points for your introduction, tells you exactly what to put in the introduction. 2 points for that. And then compare and contrast for each tool, and then a conclusion. So the conclusion tells you what to put in the conclusion, and then for each tool. So probably 2 points per tool, I guess I would look at, but the strengths, the challenges, and if follow-up is needed, how that happens. So this basically tells you how to write the paper, right? So there's the introduction, there's your compare and contrast, and then there's your conclusion. As always, if you have questions, please contact me, put it in the group chat, message me, email me, whatever. I'm here to help you understand what needs to happen. So we will go back to the modules, and we covered each lesson. We covered each of the assignments. The journal for week 5. This is the reflection questions, the summary. So you have it right there to put in, copy and paste into your journal. They're looking great. Y'all are doing a great job with them. I really enjoy reading them and hearing your experiences. And then you will have the quiz. And then here are your, close that, focus areas for the week 5 quiz. Hopefully, you kind of have a feel for how I do the quizzes now. So 5 questions. These are the topics for the postpartum, 4 questions, right? Look, and a short answer, and infancy, a short answer, and then going back to those theorists, right? So those are there. Again, you have the 2 hours to do it. You have 2 attempts. I will try to go in early and often. Let me stop sharing. I think that was it. That was it. I will try to go in early and often to grade the short answer questions, so you have time to take your second attempt. So please do take your second attempt if you need it. I think that's very helpful for people. Use it as a learning guide, as a study guide. That's kind of how the quizzes are developed, to help solidify the concepts. Sorry this one took so long. There's a lot of information to cover, and I'm trying to be as clear as I can, which is difficult for me sometimes, on my expectations and your learning. So welcome to week 5, and I guess I will talk to you later. Again, let me know if you have questions about anything. I am available. So have a great rest of your week.